Our ex-panelist is Dinsie Williams, a wonderful biomedical design engineer who has worked in many transcendental projects. Her research on the challenges and opportunities of facilitating sustainable access to medical devices in Sierra Leone and Ghana are some examples of her extraordinary work. Now she's presenting Global Low Middle Income Countries Health Technology Donations. Welcome, Dinsie.
Thank you very much, Fabiola. And thank you to the IFMBE for inviting me to join this panel of women in clinical engineering. Adriana is a very tough act to follow, but I'll do my best. So I'm here to share with you information about using evidence-based practices in the donation of health technologies in low and middle income countries. Next slide, please. As you know, there are a variety of reasons for donating health technologies. Donations could be made in support of one-time standalone charitable humanitarian efforts for in the event of emergencies, for example, or in short-term health programs such as immunization exercises or for long-term capacity enhancement within a healthcare system. So the question comes up as to what actually happens to health technology donations. It is widely known that although donations of health technologies are crucial, there are several challenges globally. This image here applies specifically to medical devices, and there's a limited quantity of evidence that suggests that on average, donations account for about 80% of funds that are used to procure medical devices. The remaining 20% comes from public funds or out-of-pocket payments. Now, of all the medical devices that are purchased for low and middle income countries, or at least some examples, it turns out that only about 30% are ever put to full use. The remaining 70% are eventually abandoned after a short period of time. Again, these numbers are not the same for every country, but on average, this is what happens. So in general, if we look at the funds that are donated, for every, let's say, for all the funds that come from donors, or as we call them, transactional funders, about 60 to 90% of donated funds end up being wasted. So the WHO has been working on this issue since the late 90s. The first guidelines on making appropriate medical device donations can be traced back to as early as 1995. And key updates have been made in 2000 and 2001. So another set of updates was started last year in 2020, at least the plans. And it's interesting that the group that worked on it, including myself, was entirely made of women. So it's appropriate that we talk about that here. So next slide, please. The plan for updating the most current plan for updating the donation guidelines for the WHO is really extensive, but it focuses primarily on incorporating regulatory and policy considerations, emphasizing the role of biomedical professionals, especially clinical engineers, and setting up clear criteria for assessing the acceptability of donations. Because as it turns out, part of the reasons why we're having so much waste in the system is that donations aren't efficiently or effectively assessed before they're made. Next slide, please. So in short, the idea is that donations should be evidence-based and centered around the requester's clinical needs and the capacity of the requester or the potential recipient, as they're usually called in the donation world, of managing these donations. The idea is that if the requester uses evidence to determine their needs, then they can actually initiate the process and the potential donor can respond effectively. Next slide. The process involves real collaboration between those who need health technologies and those who have access to the funds to help with fulfilling those needs. Central to the update of the WHO guidelines is ensuring that there is a regulatory body that assesses the acceptability of these donation proposals. So let's see what this process would look like. Next slide. The acceptability assessment is a 9-step process as follows. The next slide, please. There are specific criteria in each step. Now, these criteria are similar to ones you would consider if you are actually purchasing a medical device directly. In fact, there shouldn't be much of a difference. We have heard of local anecdotes by wherein distributors and manufacturers might use donations as an alternate avenue for bringing in new medical devices only so that they can have a captive client in the future to purchase consumables. However, if they ask the right questions, we can be sure that their devices are actually needed and they can be managed effectively locally. So some of the criteria goes across the board. So of course, the first question you ask, is this health technology clinically relevant? Whether you're purchasing directly or in a donation, the technology needs to be relevant to that local scenario. Will the technology meet the safety and technical regulations? If there are no regulations locally, we can look to internationally accepted safety and technical regulations, especially with regards to manufacturing. Will the device or the technology be functional on arrival? And what that means is if you follow the basic instructions and you have the appropriate staff to install the equipment, will it function as it's supposed to be on arrival? The next step has to do with whether the device is compatible with the existing infrastructure. And we've underlined the word existing here because there is sometimes a sense that when a technology is brought into a new environment, we can actually build the infrastructure around it. Usually that doesn't happen. And even if it does, it takes a long time before the equipment can actually be put to use. So it's better to have the infrastructure set before the donation is made. A very important step next is about checking that there's a supply chain that guarantees that you have enough spare parts and consumables ready for the equipment. Again, none of this is very complicated, but it's amazing how many of these steps are not followed when we're thinking of making donations. And the operating costs within budget. We all know that the purchasing price or the purchase price of a piece of a device, especially the high-end devices, is only the tip of the proverbial iceberg. The operating costs sometimes expand and overshadow that initial investment in the device. And it's often crippling for some recipient healthcare systems. The next step has to do with technical leadership. Again, something that's underlined. We've always asked, is there a technician around? Are there technical people around that might manage the equipment? But we know that now that that's not enough. We actually need technically trained personnel at the decision-making points where the acceptance of devices are made or the acceptance of health technology donations are made. And finally, in terms of actual practical logistics, does the technology meet exportation or importation regulations? And then there's a decision to whether the donation can be accepted or rejected. Next slide, please. Next slide. So if the regulatory authority rejects the donation, there's a process that you could revise and submit a proposal or abandon the donation at this time. Next slide. Even when the regulatory authority has accepted the donation proposal, what this shows that there's several more steps to go in accepting a donation. So a donation there are lots of steps involved. And so we should often think of all of these steps at the decision-making point to know that there is a lot of work that has to be done by the donor on one side and also by the recipient on the other side. Next slide. So if you're thinking this process seems extensive, well, it is, and it should be, but there are ways to make it manageable. For example, how would this work in an emergency? One of the many lessons that we have learned from the COVID-19 pandemic is that no country, not a single country, is beyond being in a healthcare emergency. So we all need to be prepared. In the event of donating in an emergency, the idea is to leverage existing successful partnerships, partner with organizations and agencies that have experience in emergencies, and focus on the most basic and universal medical devices. So what would really help is to have a centralized preset list of medical devices in every country. Doesn't matter where we are in the world. You could use the WHO's list of priority medical devices as a reference, or there are other lists that are available. And if these sets of devices are ready, then in the case of an emergency, they can be provided to donors, and the donors can then select what they can provide. I'll end with a very quick example, next slide, where in 2020, keep going, from a tertiary hospital in a middle income country, actually, that received about 480 items in an emergency. If I could draw your attention to the chart on the right, it shows that only 23% of those items were put into full use immediately. The rest went into storage. Next slide. It doesn't matter where the devices come from, aid agencies, charitable societies, public agencies, etc. It turns out that the majority of the devices end up being stored initially and are not put to full use. And in the case of an emergency, it would be the reverse would be much better. So the last word in the last slide is again that donations of health technologies need to be evidence-based. They need to be driven by clinical needs and the capacity of the recipients to manage those devices. They need to be immediately beneficial to patients, and it requires preparedness on the side of the donor as well as the recipients, and it absolutely requires technical leadership, which of course can be provided by women. Thank you very much.
Thank you, Dinsie, for your excellent presentation.